Okay, so we'll talk a little bit about weaning and liberation from mechanical ventilation. Can somebody just like tell me what is the difference between weaning and liberation? Is there even a difference between them?
Weaning is decreasing sitting, liberation is extubation. أو extubation rate.
So weaning is mainly concerned with the ventilator settings, but liberation it's actually extubation or stopping the mechanical ventilation altogether, which is actually correct. But over the years, actually the weaning as a term has been used as a gradual reduction of mechanical ventilation or a gradual reduction of the setting. Whereas liberation, you're assessing the patient if they are ready to be actually liberated from the mechanical ventilation, and then you perform the spontaneous breathing trial. So liberation is more of the concept or the process of actually you liberating this patient from mechanical ventilation. Whereas weaning as a term, when it started, it's actually the gradual reduction of the support.
Can I ask a question to the audience?
Yeah.
How many of you feel in your institution start with the left and then go to the right? This is very important because I think despite, I'm sure he's going to review the evidence, I would say we still mostly function from left to right, and most people wouldn't consider jumping right to this assessment from like assist control. And I don't even know what your slides are, but I have a feeling you understand where I'm going with my comment, and I hope that your slides, I'm assuming you're going there. But I wanted to see which, because I feel like historically that's the way we go.
Yeah.
Because you said that's how it used to be, or it's like that's actually how many people still practice.
So if you look at the weaning or the weaning process, how it actually started, first we have the intermittent mandatory ventilation or intermittent mandatory ventilation. It means that every single breath is actually given by the machine. The patient can breathe a little bit between the breaths, but the machine will not give him anything additional of when he breathes or the patient breathes. So in intermittent mandatory ventilation, what they used actually to wean the patient is using a TP style. So you stop the machine, let the patient like breathe for a few till like tolerate, etc., and then they put the intermittent mandatory ventilation. Then what they thought of, oh, let's add the SIMV, the notorious SIMV. So SIMV, basically the patient breathes also, but when he breathes, you can actually reduce the rate and synchronize the rate with the patient on a breath. And then why don't we add a pressure support to the SIMV? So when the patient breathes, the machine actually gives him now pressure support. This is actually the history, how it went. And then finally, the pure pressure support without the SIMV. But this is the pressure support that you don't use in the spontaneous breathing trial. This is the pressure support that you do by gradually actually decreasing the support. So this is historically has been actually the weaning process. And this weaning process actually studied in the 1990s, especially 1995, where actually what they did, they looked at three methods: pressure support ventilation, TPs, and the SIMV. And actually the highest success for extubation was the pressure support ventilation gradual reduction, not the actual SBT that we're going to talk about. This is compared to the TP trial and compared to the SIMV. And in this study, SIMV actually was the worst mode of mechanical ventilation to accelerate the weaning process. It has actually the higher duration of prolonging the weaning process. So that's why you don't hear it that often now when we actually start to wean patients. Then what happened is, again in 1995, they compared also other methods. Rather than doing the gradual weaning, what you do is a once daily trial of spontaneous breathing. And what happened here, they compared them to the different methods that we just talked about. And like what was found that the likelihood ratio of successful actually weaning and extubation of the patient occurs with using this spontaneous breathing trial of once daily. This is the history why now we use the once daily spontaneous breathing trial. Now, when we use the once daily spontaneous breathing trial now, this is what we call now the flow process of liberation. It's not the process of the gradual reduction. So the process of liberation will start actually with screening, like who's the patient, who you think is going to be ready to start the spontaneous breathing trial. Then you will perform the spontaneous breathing trial. After performing the spontaneous breathing trial, you ask yourself, how long will I actually perform it? And then after that, after performing the spontaneous breathing trial, the next question is, can I extubate the patient? Each different step is actually different. So if the patient passes the spontaneous breathing trial, it does not mean at all you should extubate the patient. The assessment of both is actually different. Now let's start now with the process of screening, the first process of screening. And I'm actually gonna jump ahead a little bit in the process of screening. So when you screen the patient now, you combine actually the screening of the readiness to get a spontaneous breathing trial with the readiness of stopping the sedation or the spontaneous awakening trial. The combination of both, this was actually studied, and the study actually shows positive outcome in those patients. And this is where comes the protocols that we use in our ICUs, where combine actually the spontaneous awakening trial with the spontaneous breathing trial. And this is just like a simplified protocol, that like there are so many protocols, and every hospital has its own protocol. So let's go through this protocol step by step. So the first thing that you would do is, you will check the safety screen for the spontaneous awakening trial. Look at the list. From the list that you can actually see, these are the patients that you will consider not actually stopping the sedation or just holding the sedation, like early in the morning, like what we do in the time being. If the patient has active seizure, alcohol withdrawal, agitation, if he's on paralytic, you cannot stop the sedation on somebody who's actually paralyzed, yeah? No features of myocardial ischemia and a normal intracranial pressure. Now, if the patient passes this checklist of spontaneous awakening trial, what do we do usually? We stop the sedation. The sedation, not the analgesia. Like we stop the midazolam, we stop the propofol, etc. And then we observe the patient, and it's going to be very obvious when the patient actually fails. I don't think you even need a set of criteria. You see the patient awake, agitated, tachypneic, etc. Now you combine that, what we call the spontaneous breathing trial checklist. And look at this criteria. If you look at this criteria, all that you're going to see is that there is no agitation, saturation is above 88%, FiO2 is low, PEEP is low, no features of myocardial ischemia, and there are no vasopressors used. This you need to take it a little bit with a pinch of salt. If the patient does not have features of shock, is on norepinephrine 0.1 or 0.2, it's not actually something to prevent you from doing the spontaneous breathing trial. And the patient has to have an inspiratory effort. You cannot do a spontaneous breathing trial and the patient is not breathing.
Notice mode is not on that list.
Yeah.
This is important.
The other thing is in this SBT safety screen, yeah, you don't see the other measures that were taught before, like the negative inspiratory course, or maximum expiratory pressures, or what is the tidal volume, etc. And something you don't see here, the patient ABG. So if you are like in a setting where you can actually do change in the ICU and be cost effective, think about no indication for ABG before doing the spontaneous breathing trial. Because these measures are actually very simple measures to actually look at. Then you perform the SBT, and we'll talk about the SBT. Now, after you perform the SBT, you look at the SBT failure, and again, SBT failure, it's very obvious. The patient desaturate, tachypneic, etc., all these things. Now, anyone want to add one parameter that was used, or it is used now for SBT failure, a calculation that we do that predicts maybe the patient is going to be successfully extubated?
P01.
Shallow breathing index.
Excellent, rapid shallow breathing index. So the rapid shallow breathing index means what? Is actually the respiratory rate over the tidal volume. So if the patient respiratory rate while doing the trial is high, yeah, all right, and their tidal volume is low, so that index is actually high, yani more than 105, 200, etc. It tells you if maybe the patient is not ready to be weaned and extubated. If the rapid shallow breathing index is low, namely less than 105 in the original study, then at that point it means the respiratory rate is low and the tidal volume is high. Maybe the patient is ready to be weaned and extubated. But to challenge that, a study actually that came in, I think this is 2016, 2006. So in this study, they looked at the rapid shallow breathing index, and there were like two groups in the shallow breathing index. One group, they used it for the weaning, one group, they didn't use it. And what was found in that study, actually using the rapid shallow breathing index increased the median weaning time by like to 2 was in if you don't use it, and 3 if you actually use it. So it prolonged actually the weaning time if you use it. Okay, so the recommendations actually from this particular study is don't use it as a sole calculation to decide whether to wean and extubate the patient or not. The other safety and criteria that you have might be enough. And in the latest guidelines actually of the ATS in mechanical ventilation, they clearly said it should not be used as a factor to make you decide whether to wean the patient and extubate them.
How many use the RSBI before initiating an SBT or as a decision to initiate an SBT? Anyone? That was traditionally, it was used as a predictor of SBT success. It still can be used that, but it was also, like they pointed out in this study, people were then not performing an SBT because they failed the screening. What most people have moved to now is exactly what this paper is doing. In Toronto, the whole Toronto area has a standardized protocol for spontaneous breathing trials, and they look at the RSBI after they start the SBT. So they decide to do it anyways. They monitor. If the value is poor, then they just monitor the patient closely for 15 minutes for any other signs of failure, and then if the patient tolerates it, they continue. So I think this is important because you may encounter places that still use it as their screening to start an SBT, and what he's pointing out nicely is that we shouldn't wait to do an SBT based on this number anymore.
Any question about the screening before we move to the SBT? Okay. So now we're going to go to the SBT, or how to perform the spontaneous breathing trial. Spontaneous breathing trial, basically, it's a trial you use it on the ventilator. It's related to the ventilator setting. So there are different ways to do it. You can put the patient on a pressure support ventilation with a low pressure support, like 6, 8, and the argument here is this pressure support that you are providing is actually overcomes the resistance of the tube that the patient has compared to no pressure support. Or you can do a TPS trial where you just put the patient on oxygen without any additional support. Or you can do a CPAP trial where you actually put the patient on only a CPAP, which is like PEEP. You put the pressure support 0 and the patient is on a PEEP of 5. So you have the three methods. The argument is the pressure support ventilation is actually better because you do the compensation of the tube, yeah? But actually you need to think about it a little bit differently. When they compared it in different studies, the different methods that are used are actually equal. So no one study is actually better than other. It depends on what you are looking at. Pressure support ventilation makes you very highly tolerate the spontaneous breathing trial. But it doesn't tell you that the patient actually was ready to be weaned and extubated. So what difference actually that makes, yeah? So if you have a patient who's ready to wean, you want to put him on spontaneous breathing trial. If you put him in a pressure support and observe him throughout the SBT, he will look somehow more comfortable compared to a patient who you put them on a TPS trial. But if you extubate both patients, all right, both patients are actually going to be the rate of re-intubation for them is going to be the same. It doesn't matter. So it tells you that the pressure support ventilation, it actually makes a difference in you tolerating the SBT, not in predicting which patient is weanable or not. All right, so this is actually the distinction that the studies actually did. So if you want to choose, you can choose pressure support ventilation, or you can use actually the TPs. The only advice about TPs, you should use it actually as a trial, like the trial, not to put the patient on that TPs for 24 hours, just because there is a high risk of the patient developing acute collapse. You're not providing them with any PEEP. So this is the trial itself. So now let's talk about the duration. What is the optimal duration for a spontaneous breathing trial? So you put the patient now on a pressure support or a TPs. How long you going to observe them for?
30 minutes to 2 hours.
30 minutes, 2 hours. Which one you're going to choose, 30 minutes or 2 hours? Huh?
What would be
No,
your
if they-
minimum? Let's say they tolerate it, would you go to 2 hours or 30 minutes, or what would you do?
So 30 minutes is actually enough based on the studies, and this study here like compared 30 minutes to 2 hours, and there's no difference between them in terms of predictability. Like myself, I use 30 minutes, but to be honest, sometimes if I'm not very well sure, like if the patient's gonna be tolerating the extubation or not, or he failed actually before, I would say give him additional 2 hours, but there is no difference between them. So what I recommend is actually 30 minutes. So now after you decided that the patient passed his SBT, yeah? Okay, when can you extubate the patient? Can you extubate the patient, or you need to look for other criteria?
What was the leak?
Scuff leak, but that's not the most important one. Any other important tests?
Occlusion pressure.
Hmm?
Occlusion pressure is creating negative pressure when
Occlusion pressure will tell you more of the weaning. It will not tell you about the readiness for extubation. So extubation is about airway. It's not actually about respiratory load or respiratory mechanics. So the criteria that you should use for the extubation is different than the criteria that you use for weaning. Can you think of any patients where you can wean them, they don't need the ventilator, but you cannot extubate them? Very common patients we see.
Respiratory muscles weak.
Respiratory muscle weak, that's actually related to the weaning. It's not related to the extubation.
Oh,
Patients with
extubation.
coma,
Okay.
yeah, the patient who's
No, GCS we need to.
yeah, patients who's comatose cannot protect their airway, yeah? Basically, we tracheostomize them and they are on trach mask. They don't need the machine. Clear?
This is an important point because some people will avoid this entire process for patients who are unconscious or in a coma. They just decide, we're not going to extubate them, so why wean them?
Why wean them?
And this is a very important point because by the time they wake up, they will be so atrophied if we support them for 3 weeks with a ventilator that, so the earlier you do this, despite, again, and in the criteria that you show, there's nothing that had to do with their brain status, it's just can they trigger the ventilator and are they on reasonable FiO2 and PEEP? And you may find that the patient doesn't need ventilation, but the airway.
They need the airway. Clear? So how will you assess the airway? Well, like we have clinical sense to it, but there are actually studies that looked at the airway. So this is a study that looked at neurological status, cough secretions, and the extubation outcome. So the most important ones that you can see here, so this is actually the cough pressure flow, I think it's called, or like how strong the cough actually is, secretions, and the ability to do tasks. Like if the patient is awake, all right, obeying commands, able to do certain tasks, yeah? These are the ones that has the higher sensitivity and specificity and likelihood ratio of predicting whether the patient is actually gonna be maintained, extubated or not. This study actually was older, I don't remember when was it, I think it was 2004, yeah. But there is a newer study actually, which I find it interesting. So in this study, they looked actually at patients, those patients, when they actually fail extubation, whether the failure of the extubation is more related to airway-related factors or non-airway related factors. And if you look down there, actually the blue one is airway-related and the pink one is non-airway related. So look at the SOFA score in the beginning. SOFA score is like basically tells you how sick you are, yeah? So it's not actually related to the airway, it's related to usually respiratory muscle weakness because of the severe SOFA score that the patient actually has. Strong cough, it's related to both airway and non-airway. Because if the cough is not strong, you will accumulate secretions, you don't have a higher chance of developing pneumonia. Copious secretions, it's related actually only to airway failure. It's not related to non-airway failure. And you can go through it. Intubation for acute respiratory failure, intubation also for coma, BMI, and female sex. It's also related to the airway failure, and it's consistent with previous studies. So that's why after you wean actually the patient and you come to the decision to extubate, you need to think to yourself, is the patient ready for extubation? And on the other hand, if the patient is not ready for extubation, are they actually weanable? And this is where you come to the decision of tracheostomizing the patients or assessing the goals of care. So I'll just end with a summary. So first of all, think from now on with liberation. Don't think actually in terms of weaning. And when does actually the time of the process of liberation starts? When does it start? Huh? When does it start? Like, let's say you admit the patient, you intubated them, yeah? When will the process of liberation start?
After reaching the lowest about
After what?
reaching the lowest about
Actually,
At
the,
the time of admission.
excellent, yes. So the process of liberation actually starts from the day of admission. Like the day you admit the patient and intubate the patient, this is actually where you start. When are you going to liberate the patients?
The
Because
ultimate goal of mechanical ventilation is to stop mechanical ventilation. After all this day, the bottom line is, once you start it, you want to stop it immediately.
So
You don't want
always,
to do this stuff.
so always think of liberation rather than weaning. Protocolized liberation, it's actually a game changer in the ICUs. Most of the protocols, for some reason, the studies, they started at 7:30 in the morning. You can choose 7:30 or you can choose 8:30 or 9:30.
Usually has to do with the shift change
I
on
know,
T's
yeah.
for North America.
Remember to do a spontaneous breathing trial. Spontaneous breathing trial, it's actually once daily. That because actually the spontaneous breathing trial, when you do it, you're exercising the patient, it's effort. You will need 24 hours. And this is proven by studies that the fatigue that you cause in the diaphragm need actually to recover. You can use pressure support or you can use TPs. 30 minutes in most patients is enough. And when you come to extubate, think about the extubation criteria. President, questions? I can continue with difficult to wean patients, but it will take another hour. But you can ask me questions if you have.
This protocolized liberation, how do most of you have like a very protocolized structure for doing spontaneous breathing trials? One of the we also do in Toronto. What I highly recommend is auditing your charts often. You may find that many people meet all of the criteria for spontaneous breathing trial, yet they do not perform one. Again, many of the times it's because maybe the patient's in a coma, they're not awake, they're heavily sedated, so they're just, as long as the reasons are documented rather than they just didn't do one. We published a study, there was the protocol, so there was a study coming out on PAV versus pressure support. It's completed, I'm hoping it'll be published this year. We're part of the study in Toronto, and one of the things we noticed, and we published this, we use this protocol every day. They have to meet criteria. If they met the criteria, we would initiate a spontaneous breathing trial. But for enrolling patients in the study, they had to meet certain criteria. But if they meet certain criteria, we had to perform we had to look to see if they passed a spontaneous breathing trial. If they did, we could not enroll them in the study. So we would screen all these patients. And what we found is that most of the patients met criteria for spontaneous breathing trial. So we couldn't enroll them unless we performed a spontaneous breathing trial. And I think something like over 70% of the patients passed the spontaneous breathing trial. So no one had done one. The anticipation in the study would, before I can even screen the patient, the physician has to say, we expect this patient to be on the ventilator for at least 24 more hours. And we would screen these patients and they would end up passing the spontaneous breathing trial. And I'm like, they don't need a ventilator, so maybe just wake them up, I guess. Like if they're still sedated, but so ensuring that you protocolize it and that you actually do it. As a research coordinator, I had to screen many patients, so I had to do it. But you found many patients met the criteria and nobody had done it. And then when you do it, they pass. It become a very different conversation on rounds when they passed it. So, yeah. So if you have protocols, if you're in a management role or a leadership role, maybe do some auditing, see
That's
if you
what
can.
I'm trying to do
Yeah.
currently.
And say, see if maybe there's some improvements there, because you may actually be able to do some specific quality improvement projects to improve and reduce your time of ventilation.
One thing I want to add about the SIMB, we've been talking so badly about it, yeah? You need to think about the SIMB, it's used in acute weaning, not in prolonged weaning, like patients who are actually in the long-term facilities, etc. Some of the long-term facilities, they adopted a protocol called TIPS protocol. So the TIPS protocol, actually, you'll see it's all based on SIMB. So, and they published data where actually success of weaning with that TIPS protocol is around like maybe 60% or 40%, I don't remember. But the SIMD we're talking about is like in the acute weaning in a patient who's admitted to the ICU for 7 or for 15 days.
And what about the CBAM?
CPAP mode is used as a spontaneous breathing trial. Like it's not like as a weaning. That the first study where I mentioned the SIMD, that was the gradual weaning that was used before.
What would you do if you have a difficult to extubate
Okay. So if the patient is weanable,
It is winnable, like
Winnable.
it is a for longer days. Like,
Yes.
what would you do?
okay.
I know that eventually you will do trade, but
Yes.
in between, can we do something?
Now, when you say can't extubate, you mean like they can't liberate, like you can't perform SPTs, they don't tolerate spontaneous breathing trials, is that what you mean?
They tolerate spontaneous breathing.
She means airway
So it's
extubation.
just an airway issue?
Yeah.
It depends on the cause.
Yeah.
Like, so if one of the most common causes is actually us believing on the cuff leak. So we think that the cuff leak, actually the patient does not have cuff leak, so don't extubate.
Yeah, this is the common answer when we ask the doctors why you are not extubating, they mention this one.
But the cuff leak, I didn't mention the cuff leak, but the cuff leak is not a good test actually to, yeah, many patients with no cuff leak, we basically extubate and they do fine.
It's not a very good predictor
It's
of
not a very good
post-extubation
predictor.
stridor. It became this criteria, I think, because maybe a few catastrophic historically. But we actually, we published a survey, and you'd be surprised that most people don't use it at all. And some people use it, so few people use it as a decision to extubate. Most people do not, but there are definitely pockets around the world. This was an international survey that we did.
It's
can-
mainly
can
because
use-
of stridor to assess the stridor or tip.
But it's not a very good predictor
It's
of
not a very
post-extubation
good
stridor,
predictor.
so if that's the reason you're not, so the only reason you should look for a cuff leak is if the person has a very clear indication of airway edema. So if there was airway injury, this is the kind of patient you may want to monitor it. But even at some point, you may need to make a decision to just go ahead and try to extubate the patients. We are doing a randomized trial now. I think we published the feasibility study and it's feasible. But basically, we were blinding the physicians from cuff leak tests. And then they had to make the decision whether or not to extubate the patients. And I think what's interesting is there were more complications in the patients we did the cuff leak test for than there were with patients like, again, it wasn't statistic, it was a feasibility study. It wasn't, we're doing another one that's gonna be powered to actually show any differences in reintubation rates. But right now, it's just a proof of concept, like, does it actually matter? And essentially, it didn't matter if you knew what the cuff leak test was or not. So the reason why we're doing the study is because the survey is so different across practices. Some people don't do it, some rely on it for extubation criteria. We decided to say, okay, well, what happens when you don't know what it is and you just have to extubate your patient?
The baseline is like we don't make the decision to tracheostomize the patient just purely that they don't have the cuff leak.
Yeah, I had a patient, the decision to take him was the cuff leak.
Maybe there was another reason, like an airway trauma or if
Do
there
they
is,
have-
if
do they
there
have
isn't,
any-
it shouldn't be
No,
just.
but thankfully, we extubated without thing.
Okay.
Oh, so he didn't get the treatment,
No,
you mentioned,
no.
okay.
And he tolerated.
Honestly, I've come across
We have many patients.
some of our patients who ended up tracheostomized in the ventilatory settings, but never off the ventilator. And most of them, as far as I remember, I'm not sure if it was only the cuff leak or something else, but they ended up coming to me to the online terms. So they came to me in the ward with minimum ventilatory setting, and they're done with like 20, 30 days in the ICU, and no other indication to stay, so they come and land in the ward with minimal ventilatory setting, tracheostomized, perfectly fine, fully awake.
Maybe because
I started
respiration
feeling-
management
So,
was.
I think what they have in common was just very short neck, severe OSA, valvular history and herpes. But there was nothing from the criteria, it's not, yeah, from the difficult liberation criteria, the one that you mentioned.
And maybe these are just patients who failed spontaneous breathing trials and they needed
Possible.
prolonged ventilation.
Possible.
We definitely will not start any more lectures. Any questions about any subject that you learned today or that you hope maybe we do next time. Again, I'm hoping they will send you some form of survey. I haven't asked if they would, but most people that host workshops will get feedback from the guests. So I assume there won't be any negative feedback on how mean we are. We hope for feedback in terms of what we could do next time. Again, suggestions of maybe having a more advanced course for respiratory therapists looking for advanced measurements versus other clinicians or physicians that just want more of a basic understanding of mode settings. That's a very good suggestion that was pointed out to me earlier. Those type of things would be fantastic because so far I've been here for less than 24 hours, 24 hours now, and I thoroughly enjoy my visit, so I would absolutely come back to do it again.
I would have loved to have more hands-on experience. with
Yes,
the
so
place.
when we first designed it, so basically, Dr. Fares was like, can you get a workshop together, and then I'll get someone who can help here, and then of course my other Toronto colleagues were available as well. So I literally put together like common topics that we use for symposiums in Toronto. But in Toronto, it's almost all like critical care fellows and respiratory therapists, so they're all very interested in more advanced mechanical ventilation. So when I submitted it, again, I wasn't really told, he said, what would be the target audience? And I said, it's people who basically manage ventilators or are familiarized with ventilatory patients. So the assumption was that it would be a bit advanced, but because it was only 4 of us, and I wasn't sure the expertise of everybody, like I know what I could do in a workshop, but everyone has their own expertise. So I think with the feedback, we probably would design something better next time, that we would maybe break up into smaller groups and have some more hands-on stuff. But it would be very different from like the basic management versus like advanced measurements. Like I would clearly love to do advanced measurements, but
Maybe a pre-course material
mhm.
and target the audience, or maybe divide them, and maybe a couple of days instead of just one.
Yeah, like the symposium we have in Toronto is 3 days.
Yeah.
And like at one point, like there's literally someone putting an esophageal balloon in their nose to show you what it looks like on a monitor. So we get pretty, we don't do it to you, but we get pretty advanced with it, but then we would have you do measurements with it. So there's definitely a lot of interaction opportunity. The other thing we wanted to do first, I think, was just test the waters. Because imagine if we had created all these workshops on all this stuff and some of you were like, I rarely see a ventilated patient, why would I want to learn how to do a PIOC maneuver on the ventilator? So I think now that we'll get more feedback, we'll be able to design a workshop that's better.
I mean, that's at least my hope. Would you be involved next time too, Ethan?
But to be fair, as a physician, we came here just to make the principles and the basic things. Now, thankfully, we have the knowledge, and you raised, all the team raised our knowledge and attitude, and we take this to practice. We faced multiple patients with mechanical ventilators in our work.
Yeah.
So
And
I
we will
think
be
we
able-
have to know what to do with
Yeah.
this patient.
And we were asked for our slides, so we will provide our slides, probably like PDF format. And you'll be able to review them to sort of remind yourself about certain concepts. You're all, I'm assuming, attending the conference this
Yes.
week. I know, like myself, I'm giving a talk on airway opening pressure, so I briefly mentioned it. We didn't get to it in the workshop, but you'll see. And it'll be a 20-minute talk that's very specifically 20 minutes, because they will be holding up the sign. Transpulmonary pressure, I'm talking about that as well, which will just sort of build upon what Dr. Del Sorbo mentioned. And I think the third one I'm doing is,
Airway closure?
No, I'm doing airway closure, transpulmonary pressure, and another asynchrony talk. It's asynchrony consequences of management. It won't be nearly as long. There's going to be no polling. Like I knew I had a whole hour to poll and make you do the questions. But tomorrow you'll feel very smart in the whether it's tomorrow or the third. You're going to recognize some of the examples and be like, I remember that picture. I use the same pictures for all of the slides. I'm going to have to start getting new pictures because next time I poll an audience, you're all going to, I recognize that. You'll have copies of my slides. You know exactly what it is. You'll be able to cheat.
I want to know, we have PPS and
Mhm.
and I'm not really familiar.
So you have the drag event
Yeah,
over here?
we have the regular ventilator, we have the surgery, we have the Hamiltons, we have, but we never use the PPS.
So I have used it. I built a whole protocol on how to set it. I can tell you from a proportional load standpoint, this is the easiest way to do it. Now, this company, I think, has stopped for 2 years now. I would only hope that they would sell their path technology to companies that have it and maybe they can change it up. This one is a no-brainer. You set the percent of total work. With PPS, you have to decide how much compensation you want to have for flow issues versus elastic issues. Now, the good news is most patients in the ICU will have a normal resistive pressure.